Phaeochromocytoma. NB. In adults, phaeochromocytomas were known as the 10% tumor, reflecting approximately 10% extraadrenal, 10% bilateral/multiple, 10% malignant, 10% familial. However, this is now considered to be out of date, with up to 25% known to be familial, Table 24. In addition, the prevalence of bilateral tumors is greater than 10% in certain familial syndromes such as multiple endocrine neoplasia type 2, MEN2, and von Hippel-Lindau syndrome, VHL, whilst in childhood a higher proportion are extraadrenal and malignancy is more common. Etiology and pathophysiology. Originating from the chromaffin cells of the sympathetic nervous system, the majority of phaeochromocytomas arise within the adrenal medulla, with a smaller number derived from sympathetic ganglia. They commonly secrete noradrenaline, norepinephrine, and adrenaline, epinephrine, but in some cases significant amounts of dopamine may be released. As with many other endocrine tumors, the diagnosis of malignancy depends on evidence of local infiltration or distant spread, since histological appearances do not reliably distinguish benign from malignant tumors. So far, germline mutations in 5 genes have been found to cause familial phaeochromocytomas. RET proto-oncogene, MEN2A and MEN2B. VHL gene, von Hippel-Lindau syndrome, comprising renal cysts and carcinomas, pancreatic tumors and cysts, retinal and craniospinal, e.g. cerebellar, hemangioblastomas, phaeochromocytomas, endolymphatic sac tumors and epididymal cyst adenomas. NF1 gene, neurofibromatosis type 1, von Recklinghausen's disease. Mitochondrial SDHB and SDHD, familial paraganglioma and phaeochromocytoma syndromes. Succinate dehydrogenase mutations are the most frequent cause of familial phaeochromocytoma and are important, as patients with an SDHB mutation typically exhibit more aggressive disease with a high incidence of malignancy, Table 24. They are usually extraadrenal, mainly occurring as paragangliomas in the head, chest, and abdomen. SDHD mutations are maternally imprinted, thus only carriers who have inherited the mutation from the father develop the disease. Epidemiology. Rare, accounting for 0.1 to 0.6% of all cases of hypertension in general outpatient clinics. Many remain occult and are only diagnosed at post-mortem. Clinical presentation. Cases may come to light during the investigation of poorly controlled hypertension, when direct questioning reveals an array of other manifestations of catecholamine excess. These are frequently reported to occur in an episodic or paroxysmal fashion. Occasional cases present with pregnancy-associated hypertension, myocardial infarction, cardiac dysrhythmias, or a dilated catecholamine cardiomyopathy. The incidence in normotensive asymptomatic subjects is rising, due to increased use of high-resolution imaging and screening for phaeochromocytoma in subjects with predisposing genetic mutations. About 5% of all adrenal incidentallomas are phaeochromocytomas, with about 25% of all phaeochromocytomas now discovered incidentally during imaging for unrelated disorders. Commonly reported symptoms of phaeochromocytoma: headache, sweating, palpitations and forceful heartbeat, anxiety, tremor, nausea and vomiting, chest and abdominal pain/dyspnea. Note that the triad of headache, sweating and palpitations is considered to be highly suggestive of a diagnosis of phaeochromocytoma. Physical signs. Features of increased sympathetic activity are often present during a paroxysm, e.g. tachycardia, sweating, pallor, not flushing. Hypertension may be sustained or episodic, and approximately 50% of cases exhibit orthostatic hypotension, the latter reflecting intravascular depletion in response to long-standing hypertension. Investigations. This should be approached in 2 stages. Confirm catecholamine excess. Localize the tumor. Confirm catecholamine excess. Urinary free catecholamines and their metabolites. 2 24-hour urine collections for estimation of urinary free catecholamines, adrenaline, noradrenaline, and dopamine, are the most widely used screening method. Assays for urinary catecholamine metabolites, such as total metanephrines and vinylyl mandelic acid, VMA, are routinely performed in some centers, although both are associated with a significant false negative detection rate, lower sensitivity. Measurement of urinary fractionated metanephrines, normetanephrine and metanephrine measured separately, is highly sensitive but less specific and is not routinely available in most centers. Plasma catecholamines. Measurement of plasma adrenaline and noradrenaline levels can be useful in cases where paroxysms are infrequent and short-lived, such that urinary estimations are within normal limits. Normal plasma catecholamine levels measured during an attack make it very unlikely that the underlying disorder is a Phaeochromocytoma. Plasma-free metanephrines. Plasma-free metanephrines, normetanephrine and metanephrine, afford greater sensitivity than plasma catecholamines due to continuous production of O-methylated metabolites in tumors. Although assays for plasma-free metanephrines are not yet widely available, their ability to offer a highly sensitive, 99%, and specific, 89%, mode of screening for Phaeochromocytoma means that they are likely to find increasing use. False positives. There are many causes of false positive biochemical screening. These fall into 2 groups. 1. True catecholamine excess, due to A. Drugs, tricyclic antidepressants, phenoxybenzamine, monoamine oxidase inhibitors, levodopa, alpha-methyl-dopa, sympathomimetics, calcium channel blockers. B. Stimulants, e.g. coffee, nicotine. C. Anxiety. D. Disease states, e.g. myocardial infarction, heart failure, cardiogenic shock, obstructive sleep apnea. 2. Interference with analytical method, different depending on assay but including coffee, labetalol, levodopa, alpha-methyl-dopa, paracetamol, and sympathomimetics. Most false positive levels are significantly lower than in Phaeochromocytoma. Repeat the test, having stopped any interfering medication, and consider an alternative screening method. Clonidine suppression test. Clonidine acts via presynaptic adrenergic receptors to block catecholamine secretion and can be used to distinguish increased noradrenaline release due to sympathetic activation from autonomous tumoral secretion. Failure to adequately suppress plasma noradrenaline in response to clonidine is highly predictive of Phaeochromocytoma, 97%, but a normal test result does not exclude Phaeochromocytoma, negative predictive value only 75%. Use of plasma normetanephrine increases the positive and negative predictive values to 196% respectively. Localize the tumor. CT and MRI. CT scans of the abdomen and pelvis are commonly used. T2-weighted MRI with gadolinium enhancement has similar sensitivity and specificity to CT, but lacks concerns about radiographic contrast. The tumor typically exhibits a distinctive bright white signal on T2-weighted images. NB. Intravenous injection of certain types of contrast media can precipitate pressor crises, and accordingly alpha and beta adrenergic blockade is recommended prior to examination with these agents. Radioiodine labeled metaiodobenzyl-guanidine. 123 IMIBG, scintigraphy 123 IMIBG, which is taken up by chromaffin cells, is useful in localizing both adrenal and extra-adrenal tumors and is the first-line nuclear imaging method. Pre-treating with potassium iodide blocks thyroidal uptake. A newer promising localization technique, 18F labeled dopa positron emission tomography, PET, offers the higher spatial resolution of PET scanning and may allow detection of smaller lesions not visualized with 123 IMIBG. Genetic testing. Sporadic forms of Phaeochromocytoma are usually diagnosed in individuals aged 40-50 years, whereas hereditary forms are diagnosed earlier, most before age 40 years. Genetic screening in Phaeochromocytoma/paraganglioma syndromes is a hot clinical topic, with recent advances in diagnosis and genetics now challenging the traditional rule of 10 for Phaeochromocytomas. The prevalence of extra-adrenal tumors is up to 20% and prevalence of bilateral or multiple tumors is higher in some familial syndromes such as MEN2 and VHL. Up to 1/4 or more are hereditary. It has therefore been suggested that all patients with a Phaeochromocytoma should be considered for genetic testing, firstly to allow early diagnosis and treatment of other features of the associated hereditary syndrome, secondly to prompt more stringent, lifelong clinical follow-up, as recurrences are highly probable in familial Phaeochromocytoma, and thirdly to prompt appropriate family screening. Presently, cost-effective genetic screening is recommended to those with a positive family history or those aged under 50 years, especially children. Other clues that should be regarded as an indication for genetic testing include bilateral adrenal or multifocal extra-adrenal disease or the association of Phaeochromocytoma with other tumors. The clinical picture may direct genetic testing to one of the suspected genes. Differential diagnosis. Several conditions may present with features of sympathetic overactivity and thus mimic Phaeochromocytoma. Treatment. Medical therapy. Prior to considering surgical removal, medical treatment must be instituted with the aims of ameliorating symptoms, normalizing BP, correcting intravascular depletion. NB. Beta blockers must not be given to patients with suspected or proven Phaeochromocytoma until alpha blockade has been established, since there is a significant risk of precipitating a life-threatening hypertensive crisis due to unopposed alpha-adrenoceptor activity. Alpha blockade. The non-competitive alpha-adrenoceptor antagonist phenoxybenzamine is the initial treatment of choice, with escalating dose titration. Start with 10 mg twice daily and increase gradually until BP is normalized. Most cases require 1 to 2 mg/kg per day in divided doses. The alpha-1 adrenoceptor antagonist doxazosin provides an alternative for those intolerant of phenoxybenzamine. Beta blockade. The non-selective agent propranolol, 20 to 80 mg every 8 hours, is generally preferred. Surgical excision. Both traditional and laparoscopic approaches can be used for tumor removal. Adjunctive therapy for malignant tumors. Alpha-methylpyridyrosine ameliorates symptoms through inhibition of tyrosine hydroxylase, the rate-limiting enzyme in the biosynthetic process. Radioiodine, 131I, labeled MIBG, large and repeated doses may be necessary. Prognosis. Even those with malignant tumors frequently survive for many years. The extent of end organ damage is often a key factor in determining long-term outcome.